Here we are. This is the last session of the day. They saved the best for last, right?
It's called the graveyard shift, I think.
Graveyard shift. A little context here. David is chair of the board at NHS, and I'm an executive in NHS, so all of our banter should be understood in the context of how you treat your board chair, okay? So David, I think we agreed you would start off and tell us a little bit about the life science strategy and where we're going in England and the NHS.
Yeah, well, thanks, Tim. Tim is from Mass General, I should say, as everyone knows. He's a native from Boston, and he's joined us in the UK, which is fantastic. So look, if you look back at COVID, how we dealt with COVID, it was through a partnership with AstraZeneca on the vaccine development. It was our vaccine rollout within the NHS. It was working with private industry on the sequencing of the genome of the virus. It was that partnership that got us through the worst part of COVID. And it's that partnership which has got to get us through the other scourges of the day: obesity, mental illness, respiratory disease, cardiovascular disease. These big, highly prevalent disease areas which we're not touching at the moment. And so I'm going to say today that we have just entered into a memorandum of understanding with one of your companies here in Kendall Square in Boston, EQRx, biotech company here, to provide the NHS with a range of cancer drugs at very affordable prices. And I stress affordable because we have got to give access to these drugs to as many patients as possible that can benefit from them. We've got to have an impact at a population level. And too many of the developments over the last 20 years have affected too few people. And that applies not just across cancer, but a whole other range. And it is actually why we entered into the deal with the Meds company and Novartis on inclisiran to reduce cholesterol levels. It's also why we entered into the arrangement with another American company, Grail, on a cancer diagnostic for up to 50 different cancers. So this is the future for us, to work with the life science industry to get real impact at population scale in the UK.
David, that's terrific. Do you want to say a little bit more about the life sciences vision that our government just published?
Yeah, you're one of us now, Tim. I think there's three parts of it that I would draw your attention to, because they underpin everything else. The first is data. We've got to have good quality data, because artificial intelligence, machine learning is going to have a huge impact on, not just on how we deliver healthcare, but on drug discovery. And so we are sequencing the 500,000 people, whole genome sequencing the 500,000 people in UK Biobank. We're setting up Our Future Health, a 5 million cohort. Everyone will have a polygenic risk score, blood test, and follow-up. And we've got, of course, the longitudinal records on 65 million people who are within the NHS. This is an extraordinary source of data that can be hugely important in finding new discoveries for some of the worst diseases that we have. Secondly, clinical trials. We've got to help the industry take the cost out of developing new drugs. And actually, with us here in Boston is Professor Sir Martin Landray, who ran the recovery trial, which recruited 43,000 patients, discovered that dexamethasone could have a very good impact on people suffering from COVID, ruled out hydroxychloroquine, as you know, your then president's favorite choice after bleach, I think. And Martin is here this week, and we think that running large-scale, low-cost, high-quality clinical trials in the UK will also be a big attraction. The third thing is regulation. And it's interesting that in the deal that we negotiated with EQRx, it was the fact that we have the new iLab for innovative new medicines coming into the UK with the MHRA, our regulator, that I think Melanie, who is the CEO of EQRx, described it as a cherry on the cake. If we can provide good data low-cost clinical trials. I should say that the recovery trial, the cost per patient on that trial was £350 per patient in the trial. Not bad, I think, people would think. So that is a sort of the basis, the background of the life science strategy. Now, I want to ask you a question now.
Yeah.
Because you've come over to the UK at a time when all healthcare systems around the world are under enormous pressure. Mm-hmm. What can we learn in the UK from the US healthcare system?
So, I mean, I think there's real potential to learn back and forth, and I have to be careful speaking to my board chair about this. But there are a lot of things. And one thing that I would say is I anticipated before I came that the friction that I've experienced as a patient and as a child taking care of my parents here and as a clinician here, that the friction in healthcare was largely a product of our fee-for-service system. And I have learned that's not true. Actually, there's extraordinary friction in healthcare wherever you go, that the delivery of care, the coordination of all the specialized services just doesn't serve our patients well. And that occurs everywhere in the world.
So really, if you look around the world, I mean, we're very self-critical. You know, Brits tend to be self-critical, and I'm very critical of our own healthcare service. I mean, I love the NHS, but I'm also critical about it. Is that when you look around the world, no one has got this right.
Yeah.
I mean, has anyone got it right?
Yeah, I don't think so. But here's some things about the NHS that I find have extraordinary potential. And I'll list 4 of them. One is, and they actually came just like what you were saying about the how COVID exposed both our weaknesses, but also our strengths. So one of them is the NHS app, and the ability of a single app to deliver services to an entire population. So there's now currently 17 million users of NHS app, and it's growing at an extraordinary pace. We're adding more and more functions to that app.
Yeah.
You should be able to see your records on your phone anytime. You should be able to renew your medicines on your phone anytime. You should be able to schedule appointments on your phone anytime. In the US, that is possible and frequently used depending on the system that you are part of. But that sort of leaves a world of haves and have-nots. In the NHS, we're doing it for the whole country, and we are building that capacity to have all of those services for the whole country. That is an extraordinary opportunity for the NHS and for the citizens of England. So that's the first one. The second one is end-to-end redesign of care. And this is the beauty of when you have a national system where the entire care process, end-to-end, is owned by one entity, right? And so while there are, of course, divisions within the NHS, at least in theory, it is all owned by the NHS, and therefore you can reimagine from the moment a patient feels as though they've got a problem until that problem is resolved. You don't have to have the constant transaction of back and forth. Making healthcare a truly tech-enabled service, there are really exciting opportunities, and I'll just mention a couple. So the healthcare at home programs that are springing up all over England in response to COVID really reimagined the difference between what is in hospital care and what is out of hospital care. And those are currently going through a scaling process that is both expanding their use for respiratory conditions, but beyond respiratory conditions. That's exciting. The physicians are excited about it, the patients' satisfaction with it. And that's just one of literally hundreds of examples.
So let me just pick you up on that, because healthcare has always been a provider-driven business. It's a B2B business, if you like. It's centered on the hospital or the doctor. And the wretched consumer has hardly had a look in on this. Is technology going to change that fundamentally, in your view?
It will. technology. It has been changing it. There's a terrific program here, a program policy change here, open records. And as a result of that, probably everyone in this room, whether they know it or not, has access to their records, depending on whether or not the digital systems that their doctor has support that transparency. That kind of transparency enables an enormous amount of change in healthcare and puts the shoe on the right foot in terms of the power of the consumer to drive the redesign of the care from their perspective. And so another example is, so we just started sending out variation reports to the surgeons across England. So Tim Briggs, the orthopedic surgeon, has had a program called GIRFT, Get It Right the First Time. And that's been sort of in pilot, hasn't really been in industrial mode. He's been testing with surgeons around the country. But as of next week, we are starting to send practice variation reports to all of our surgeons throughout the country. So it's another example of using data, power of data, the power of analytics to make it so that our conversations are not anecdotes. They are, gee, yours looks different than mine. What are we going to do about that? That changes the nature of the conversation, both within the profession, the guild protectionism that I think you were referring to,
yeah.
and with the consumers. So I do see it's progress. It's been frustratingly slow, but it's continuing.
And do you think, I mean, if I look at the NHS, I mean, it is a much loved and unifying institution in the UK, which is both good and bad. It's good because, you know, we love the NHS. There's a sense we're all in it together. There's a sense of equality. And it's bad because we love it so much, it's more resistant to change. It's harder to change it because change is difficult.
Yeah.
I mean, do you see that? Is that something you're aware of?
Yeah, I'm aware that although having worked in change in large organizations, including a large organization here in Boston, it's not just the NHS that's difficult to change. Large organizations have mass, and it's difficult to, I think it was one of Newton's laws, to get that mass to move. Once you get it moving, though, and the process of change, it can be really exciting. And what I see in the NHS is terrific ideas. But those terrific ideas are very rarely scaled. And it's a little bit of not invented here. I actually, there's a joke about Mass General Hospital that I like to repeat that has some resonance with the NHS. And that is, lots of great ideas have come out of Mass General Hospital, but few great ideas get in. That is a constant problem in managing change. But there are known techniques to address it. Data is part of it, and governance is part of it, and really agency is a really big part of it.
So Tim, part of your title, just mustn't forget this, is improvement. You
Yeah.
are responsible for improvement. Now, we have struggled with driving improvement and innovation into the NHS for years. You know, we've tried regulation, we've tried performance management, we've tried creating an internal market, we've tried competition, and we've never really found the golden thread that can drive innovation and improvement into what is essentially a provider-driven monopoly. And
You're just not going to let go of this, are you?
I'm not going to let go of this. Now, look, we are now moving towards integration at a local level. By local level, I mean a population of 2 million people, that kind of level. Now, you at Partners here in Massachusetts, you have a lot of experience with accountable care organizations. I mean, do you think that integration at that local level is the right structure to drive improvement and population health?
I do. Yeah. I mean, that is fundamentally about that joined up care the friction that I talked about, and level loading, having care delivered in the place that it's most appropriate to deliver that care. And when you are capacity constrained, you have got to organize your system so that you match what is delivered with the patient's needs. And there is so much mismatch that goes on in this country, and I will say a lot that goes on in the NHS as well.
So you look back over, you've been with us now for 4 months.
4 months.
I think I probably described the NHS to you in glowing terms in order to get you to come over here. And the reality is maybe not quite as I described it at the time. And I say that because it's not just the NHS. I mean, and I'm going to give you a personal view on this, that I think that the way we deliver healthcare in the US or in the UK or in Europe is fundamentally broken. And I say that because the costs are so high, life expectancy is now stalled, health inequalities are rising. You know, people from socially deprived areas are falling further behind. So by most measures of success, healthcare systems are not delivering at a time when many other parts of the economy appear to be satisfying, you know, consumer requirements to a much greater extent. And if you look forward at how we might change this fundamentally, how we might move to earlier diagnosis, to more population health, to a more preventative system rather than, as we are, a very late stage sort of sickness system. What are the big 2 things that you're going to deliver for us in the UK over the next couple of years?
I was hoping you weren't going to ask me that question.
You may not agree with my premise.
No, I do agree with your premise. And I will say that the data and analytics is a huge part of it. There's a huge opportunity, not just on the supply chain stuff, but through transparency, through a tech-enabled service, that redesign. But probably more difficult, certainly more difficult, and probably more important, is what happened during COVID in the delivery of healthcare is an extraordinary vision for what is possible when everyone is working together toward a common goal. That is what is the essential ingredient of really scale change. And we have to do that again. We have to do that again, in this time not for the specific disease, but we have to do that again for healthcare. And that means everyone needs to be aligned around the fact that we need to change. And this happened, I saw this happen both on this side of the pond and ours, sorry, little slip. What happened was people compromised on their position in order to see the greater good, because they knew they had to in the face of the pandemic. And if we can organize ourselves around a vision that allows people to take a step back and view the historical context here. You know, I might actually just say, you know, I find it, when I get frustrated with the pace of change, the historical context, I believe, that frames this moment in time is the fact that we're going through 2 huge human revolutions in our understanding. And that is, our understanding of biology, and human biology in particular, is exploding at a pace unimaginable just half a century ago. The same thing is happening with digital and data. It's just explosion of information. Now think about healthcare. Healthcare sits at the very intersection of 2 massive revolutions in human understanding. And we have to pause for a second and say, we don't know where either one of those two revolutions is going completely, right, with certainty. And healthcare actually is dealing with both of them simultaneously. So that gives me some historical context to think about why it's so hard to manage change in healthcare.
So Tim, I think our time is
over.
Pretty much up. But just to summarize what you just said then, which I think in many ways is also the answer to issues like climate change. It is that combination of human behavior and science.
Yeah.
And if we can get people motivated and incentivized and driven and incorporate these extraordinary changes that we're seeing in biology, chemistry, and data analytics, then there's hope, I think, for all our healthcare systems. So thank you all.
Thank you all, ladies
very
and
much.
gentlemen.
Thank you.
Thank you, David.
Thank you.